Welcome to Positive Recovery MD. If you're listening, chances are you want to create happiness around you and thrive in your life. We're glad you're here and you've come to the right place. This podcast will inspire and motivate you to not merely survive your recovery journey, we'll give you the tools to build or strengthen your foundation to thrive and flourish in your life. Each week, we'll come together as a community to have authentic conversations around addiction, recovery, and what matters. Growth and progress, not perfection. All while developing positive habits for you to utilize in your life. To learn more, please visit positiverecoverymd.com to sign up to receive the daily positive interventions that we'll review, as well as gain access to exclusive Positive Recovery content available only to Positive Recovery MD listeners. All right, let's get started. Hi there, and welcome to Positive Recovery MD podcast. We're super excited today to have Dr. Miranda and Leah Davies with us. I'm going to have them introduce themselves so they can tell you just a little bit about themselves before we begin to jump into what I'm really looking forward to. I started to talk to Dr. Miranda earlier about this, and that is one of my jobs was on a maternal addiction program unit. And so working on what was a MAP unit down in Fort Lauderdale Hospital, I got to experience firsthand some of what it is that you guys are working on, particularly around the stigma and the shame associated with moms who are or have been consuming alcohol before they realized they were pregnant or just weren't able to stop once they found out that they were. So super excited. Dr. Miranda, can you tell us a little bit about you?
Sure. I am a professor at Texas A&M University. I teach medical students part of my time. The other part of my time, I run a research laboratory. We do work in both animal models of fetal brain development, early fetal development, and the intersection between drug exposures and fetal development. And then we also work in different human populations in the arena of pregnancy and predicting birth outcomes and such.
Fantastic. And I know Leah is just in charge of so much of collecting the data and working on it and being part of the co-chairing of the Texas Collaborative of Fetal Alcohol Spectrum Disorders. So tell us a little bit about how did you get into that?
Hi, I'm Leah, and I'm really always excited and honored to get an opportunity to talk with people that we don't normally talk with about FASD. So thank you both for having us. I've had the privilege to work with Dr. Miranda and Linda Kagi, who you guys I think know, for many years around fetal alcohol spectrum disorders. I got into this work by way of being interested in people who have to live with multiple levels of life circumstances that are adverse or difficult or challenging. And that led me to working with people interested in the area of working with persons who have intellectual or developmental disabilities. And that kind of led into learning more about substance use disorders and FASD. And so I've been working in FASD for about 10 or 12 years now.
I'm glad you guys are, and I'm glad we had this opportunity because I reboarded a couple years ago. So I think it was the third time that I took the boards. This was the first time it was part of the American College of Medical Examiners. I'd been part of ASAM before. But what strikes me is how there's so much more prevalence of the FASD when you include the spectrum than the typical fetal alcohol syndrome that we learned about when I was in medical school. And it's just got the characteristic faces. You can almost pick them out of a crowd. And now it seems like there's a lot more that go undiagnosed. And I can't wait to kind of unpack a lot of the points about it. And so thank you guys so much for the work that you do. I know that it makes a difference because from where Julie and I stand, prevention and early intervention isn't really something that we're doing. We don't have a facility that identifies, grade age school kids. We're treating maybe the mothers. We're treating some of the patients who have it that have gone undiagnosed, that they themselves have developed a substance abuse disorder or that was misdiagnosed. I'll see somebody in my outpatient practice who was misdiagnosed as ADD or ODD or something. And this is actually what they have. And it takes a lot more time than digging than I think what a lot of people are used to doing. So let's start out. Why don't, Dr. Miranda, would you start out by telling us what is FASD, like a basic explanation of what it is for our listeners?
Sure. At the very basic level, fetal alcohol spectrum disorders is a series of physical signs as well as behavioral and brain deficits, problems, anomalies that are associated with exposure to alcohol during pregnancy. And these signs can range from what we know of traditionally as part of the FASD continuum, which is mid-face anomalies, growth deficits, decreased head size, problems with behavior like attention deficit type disorders, memory, ability to work with numbers, to very subtle deficits. And sometimes these deficits don't go together, and which leads to the issue that you mentioned. The mid-face anomalies that we associate with fetal alcohol syndrome actually occur in a very, very tiny fraction of the cases of individuals who might be affected by prenatal exposure to alcohol. A vast majority of these individuals who might have equally severe behavioral anomalies may never show the mid-face deficits like a flattened filtrum, thin upper lip, epicanthal folds, and so on and so forth.
I was surprised to see that, like, based upon the information that I read, that it's like 1 in 20 that these characteristics can show up in. And I think for me, and probably for our listeners, some people may be able to identify it visually, but what you're saying is that that's really not all that common to see it. So what would we expect to experience? Like, what would that behavior look like?
Many people with a fetal alcohol spectrum disorder, as Dr. Miranda said, not necessarily fetal alcohol syndrome, FAS, but across the spectrum, people report deficits, difficulties with executive function. So that concept might be something your listeners are familiar with, but just for sake of a little explanation, that executive function is the set of skills and processes that all of us use in our life to order our day. And they are involved. Executive function is also involved in things like thinking abstractly. So it can help us associate things we're doing now with what might come from those behaviors or those activities in the future. It's kind of oriented around planning and ordering ourselves. And so if you step back and think about how executive functioning differences might play out in our lives, it's omnipresent. So if a person has trouble, let's say, remembering order of things, it might be difficult for them to be able to know when to leave to get to work on time. And it might be difficult for them to know how long learning a new skill will take once they're at work. And so they might, because of these kinds of differences in the way that they think and plan, it might make it hard for them to have success in a traditional employment kind of situation, just as an example. But there's other manifestations of executive functioning deficits, which are common for people across IQ range within FASD spectrum, that include things like sometimes some social skill difficulties. And those, again, can, especially in combination, can create difficult situations for people in their life.
Yeah. So to jump on something you said earlier in that little bit, which was great, I'm pretty sure a lot of the listeners think of executive functioning as something that maybe an executive does. So the way you explain it is great. What I found to be most interesting when I was researching this and watching a lot of YouTube videos about kids and young adults and then adults who have it that speak out, first of all, I was taken aback by how high functioning they were, because I'd always thought that wouldn't be the case. Second, some things that keep coming up were exactly what you said, was memory, was spatial memory, and not in terms of, I don't know if I said that right, but if you gave somebody a set of 5 instructions, they'll lose 3 and 4. And so in that case, it sort of looks like ADD, right? And there's also the verbal instructions aren't as good as maybe visual. Mm-hmm. And there's a lot of resources out there for teachers, like what to do if it's in your classroom and maybe this is a kid to identify, which I think is great because there was this big push for ADD. But like, what do you guys say to parents who might suspect it or might not suspect it, have issues with the children and the shame stigma of admitting that they drink? And the problem is even one drop, I saw some of the experts say, could cause it. So it's hard to get a mother like it. I can imagine the shame I would feel myself, right? If I drank and wasn't planning on getting pregnant and I didn't know. And then all of a sudden I'm carrying around the weight of this thing, and my child who could have early intervention and get better is undiagnosed. So kind of like, can you address that piece?
Yeah, and I'm going to refer to Dr. Miranda here in a minute, but my first response is that none of us know, even the researchers don't know categorically with any one pregnancy and any one parent what the specific amount is that does or doesn't cause fetal alcohol spectrum disorders. And so I would encourage your listeners to kind of sit with the grace, the knowledge that we do not know what any one person's consumption may or may not have done categorically done to their child. And so understanding the fact that most pregnancies are unplanned, that's true in Texas, but it's true across the country, where over 50% are unplanned or unintended. And then the rate of persons who use alcohol socially or who might have a alcohol use disorder is relatively high, as you all know, probably in the States. And so I think that we as a community have to do a good and intentional job of avoiding blame and putting ourselves away from this concept of like, there was this group of persons did this thing that caused this disability. And I think a better approach, what we should all try to rally around, is how best to support people who might have a fetal alcohol spectrum disorder, instead of, as much as possible, instead of trying to pinpoint exactly what use happened and what that use might have done to any one fetus. So I don't know, Dr. Miranda, if you'd add anything there.
Sure. To my mind, stigma and blame are probably the biggest barriers to managing healthy pregnancies and infant birth outcomes. I agree with you completely. There are such a large combination of risk and resiliency factors that can alter the outcomes, so that a certain amount of alcohol might have apparently no effect, but in another mom, the same amount of alcohol, maybe because she's under stress or any number of other risk factors, come together to create a much worse outcome. And we also forget that, one of the other problems with stigma is that we have a laser focus on the mother and her pregnancy. The reality is it takes two to make a baby. We've often ignored the role of the father in programming that pregnancy as well, even though we know anecdotally that fathers who are alcoholic or who have substance use problems will often have infants that are affected. And there's a research starting to emerge now that is showing that the exposure of the father can be just as damaging to fetal development as exposure of the mother. And so I think, if we can get away from this whole business of stigma to asking what does it take to manage healthy pregnancy? Right?
Thank you for that. That's great insight. And you're probably going to get into this, but can you tell our listeners about some of the risk factors, including epigenetics, maybe maternal age? And I know you said amount of exposure, Leah, we really don't know, but what do we know so far from research? What is the fruits of your labor kind of yielded so far?
Oh, sure. So there's been a lot of research into this arena, as you might imagine. So the dose, the amount of alcohol does make a difference, all other things being equal. But when it happens is also hugely important. So does it happen preconception? Does it happen during the period of pregnancy? And so just to go back to that, the initial discussion about the misalignment between facial features of fetal alcohol exposure and outcomes, if the face is formed during a very restricted period of time during development. And if alcohol was not present at that time, then you may never see facial anomalies. But if there was a binge episode of alcohol consumption after that, now you might see brain anomalies without facial anomalies. We also know that stress is a big player. And so if you have a co-occurrence of highly stressful conditions, in some of our studies, some of the mothers live in just terrible conditions with a lot of violence in their environment, with partner violence and social violence and things like that. Socioeconomic status, we can actually model this in animal models as uncontrollable stress. That if you have for example, to fix a car, it's one thing if you have the money to fix the car and you're just fine. It is something that you forget about. But if you don't, if you have to choose between fixing your car and putting food on the table and paying your rent, now that is uncontrollable stress that could have a very, very dramatic effect on the pregnancy outcome. Nutrition is a big deal as well. So you see, all of these things come together, and frequently they can co-occur. So somebody who's in a precarious position economically may also be very stressed and may be managing that stress by engaging in drug and alcohol consumption, all working together.
Is there any one demographic that shows the highest rate of FASD?
Fetal alcohol spectrum disorders can occur across all racial and ethnic groups. Some research that indicates there are higher rates in certain parts of the world, but it's not safe or appropriate to say that there's any one ethnic or racial group that has higher incidence. Dr. Miranda might differ.
That's pretty
hard sciences.
I understand it. Maybe one wrinkle is that people have observed that subsequent pregnancies are often worse affected And so you can infer by that an older mother might have a more affected, for whatever that's worth.
And I wondered if it's okay, Dr. Powers, to add just one thing to that, which is, as Dr. Miranda mentioned, there's this really complex picture. And as a social worker, that's what I think about often when I think about FASD. How can we look at a person's experience, including all of the things that impact how they operate day to day and what their life looks like? And that includes, as Dr. Miranda said, your nutritional status and your access to healthcare and your supportive or non-supportive system of people around you. All these things can impact the way that alcohol use changes a pregnancy. And so I think for me, we have to always be circling back to that idea of women who are facing and families who are facing large amounts of difficult circumstances, and that's a risk in its own way.
Right. Absolutely. Absolutely. We looked at demographics, and there was population specifically, if you were near the poverty level, you have higher rates of everything, heart disease and heart attacks and suicide, like all these bad things. And what they found was stress was the common denominator, but it was negative stress. It was prolonged stress, like needing a car to get fixed and you can't, because not all stress is bad. But what I found most interesting from the study of epigenetics, and that is for listeners that maybe don't know. So genetics, you get a set of genes from your parents, and like blue eyes, brown eyes, something that's just clearly passed down. Of course, there can be mutations, but epigenetics is sort of how time and environment and behavior affects the genes and expression of the genes. And we know that even we looked at grandmothers who were under stress, their grandkids had higher rates of cortisol and this type of thing. So I'm not surprised to hear, obviously, you said long time stress is going to affect it. And I think maybe it's because of coping, but also it's just that common denominator. Let me ask you guys to drill down a little bit on nutrition, because somebody might be listening and they hear that and they're like, okay, great, but what's the guidebook? So what does that mean? So what nutrition is something good to add, and maybe what nutrition is something good to avoid?
That is an arena. There's a lot of research going, including in human populations. And it could be simple as providing multivitamin supplements in a pregnancy. And believe it or not, that is not accessible everywhere. I mean, we think of it as routine when women are medically managed in the US, but a lot of women may not have that medical management of pregnancy as well, and may not have exposure. So multivitamins would be a good thing. We know that, there are things like, you talk about epigenetics, for example, things like folic acid and those types of agents, which actually tie into epigenetic mechanisms. And so nutrition can be considered in its broadest sense as a modifier, if you will. This is my take on it. Okay, so the modifier of the epigenetic influence of the rest of the environment.
No, absolutely. And can you give an example? I totally agree with you. And I mean, I can think of something. Let's say that you have maybe a predisposition to having heart disease, but you exercise and your diet is full of plant, based protein, and you do well. It's not going to show up as much, say, as if you have a diet high in sugar, which we know is an inflammatory agent, something like that. But in terms of a mother, can a mother do anything who drank unknowingly while early in pregnancy, but she stopped as soon as she learned that? Or maybe the father as well, of course, but I mean, his contribution is over with, right? But and obviously if the father is like a negative stressor on the mom, that can cause problems. But really, I think at this point, is there something a mother can do in order to maybe mitigate the risk that had happened?
Right, because that is what people that when I was in the maternal addiction program unit MAP in Florida, what I would hear all the time was like, oh my God, I didn't even know I was pregnant, and I was out, we were down in the Bahamas, I was on my honeymoon. Like those kinds of things would come up. So for our listeners, is there something that we can tell folks or we can work on in terms of coaching them?
So we know that biology in the fetal development is remarkably resilient. So actually, we all, and the developing fetus has enormous reserve capacity. You really have to inhibit processes hugely. So for example, you can have a fetus that's in the 50th percentile or the 20th percentile of its growth, and you would never see any difference. But bad things will happen if you get down into below the 10th percentile, say, for growth. So there's this, I look at it as there's this enormous reserve capacity that's actually present. And if we can tap into that, we probably will end up protecting against a lot of things, not everything. And so one answer would be it's always better to stop at any stage. Stopping at any stage of development is better than not stopping. Improving other resiliency factors, so whether they be social or nutrition or whatever, can tap into that, building that reserve. And so you might have a situation where a fetus might have the craniofacial anomalies because exposure happened during that time frame. But that doesn't necessarily mean that everything else should be equally affected. And I think maybe that should be the take-home message, that you can change.
Julie, when you were on the ward, did you hear this? Leah, Dr. Miranda, you too. I'm taken aback when I hear. Actually, I'm a little older now, but when my friends were in the pregnancy range, we were having kids, and they would tell me that their OB told them it was okay to have a glass or two of wine. And then they would, some would ask me, first of all, I'm sober, 17 plus years. And I know that, the people that drink, sometimes there's this awkwardness sometimes. And I really want to say, no, none. I just wonder how that will be taken. And if they've already been drinking, it was just going through my mind, a lot of things. I don't want to sort of come across as shaming. And what do you guys think? Because I think no alcohol is the safe amount.
Yeah, the safest choice is none at all if possible. But saying that without adding context, as you say, Dr. Powers, can be really shaming and stigmatizing. And so the next best message, in my opinion, is what Dr. Miranda mentioned earlier. Stopping at any point has positive impacts for the child's use. And if a person already has a child who was exposed and that child's already here, there are things we can do to better support persons who might have an FASD in their life. I hear you. It's really an awkward conversation. It's a difficult conversation, but it's an important one. And there's some new research around, well, not new, there's lots of research, but some new research in particular points to being approaching the conversation in a non-judgmental way, in a way that supports the fact that people's lives are complex and aren't usually a black or white. I chose to do this behavior and knew it would be bad. That's not how people's lives work, right? And so instead, if we can unpack some of our own feelings about the idea of substance use during pregnancy, and try to avoid putting anything on a person when we're talking with them about that idea, and rather say, what can we do to support you and your child, or one if it's an adult. I think that's the right way to handle this.
I do understand why OB-GYNs in particular say it's okay to have a drink or two. In their mind, they're balancing stress versus, the drink calms you down and such. And as I understand it, alcohol has in the past been used to manage pregnancy conditions as well. If I remember correctly, for preeclampsia, many decades ago. Right. And so I think OB-GYNs had a hard time thinking of something that could be good as bad. My suggestion would be, maybe instead of suggesting alcohol, to find out what other things or activities pregnant women can engage in that can calm them down. Maybe it's music, maybe it's, it could be a number of different things. And it doesn't have to be alcohol as a go-to, because it's really playing with that balance of risk and resiliency factors when you suggest alcohol.
But I have to interrupt you, because I think it's really important, and you guys know this in your world, that some people do need help to stop. We should not assume, all of us, especially human service professionals, I think, like myself, should not assume the burden is on the woman to stop because she knows. That's not fair. And sometimes a person needs support to stop, and we should offer that support always and upfront and first thing, in my opinion, because it's not as simple necessarily as taking up yoga, and that's cool, that will help you too, but also
it does get muddied because of the continuum of social drinking, where I think Dr. Powers was talking about with it's okay to have a drink or two versus alcohol dependency. And you're absolutely right, Leah, that when you get into the dependency arena, then you can't just say no. You have to support.
And so often the woman who is pregnant is really underreporting how much she's drinking, because they are ashamed, or they are afraid to report how much they're actually drinking. And they actually do need an intervention, or they do need medical supervision to support that. And so one of the things that I experienced, and Dr. Powers brought it up, when I worked on MAP, it was constantly kind of a battle between the OBGYNs and our nurse midwives or our doulas, because the OBGYNs were like, oh yeah, it's fine, just have a glass or two of red wine at night. And the doulas and the nurse midwives were like, wait, what are you saying to them? No, this is not a good idea. Let's look at other options. more in line with what Dr. Miranda was saying, like, are there breathing techniques that we can do? Is there meditation that can be done and all those things? And that was in the absence of an actual alcohol dependence type of situation. But of course, on the unit that I worked on, we took care of the sickest of the sick. And oftentimes those were folks that were working with an addictionologist, and we had a whole team of professionals to help them, because it wasn't just an alcohol use disorder. It could have been an opioid use disorder or the like. So it's just a variety of different things that we were treating. But the support that you're talking about for pregnant women who have an alcohol use disorder or substance use disorder, what does that look like? And then how does it extend? Like, how then after she has and delivers, does it incorporate into the family process?
Wonderful set of questions. One thing I want to unpack that I think lends itself to the answer, hopefully you're thinking about, is that we also know that for some women, they might not have an alcohol use disorder. They might have a different substance use disorder, but they also use some alcohol. And unfortunately, when it comes to fetal alcohol spectrum disorders, as Dr. Powers started out earlier by saying, some alcohol use looks different from person to person. So what is that measure of some? And when we identify a child who might have changes based perhaps on an apparent substance use, we really should be looking more universally at, is FASD a part of this picture or not? Even if the mom identifies as her substance of choice was cocaine instead or something else, was she also using that alcohol when she couldn't get it? Maybe. And instead of just saying, well, this child, they seem fine and their growth is fine, like, let's look at the long-term impacts and try to unpack them. And so that's kind of where I wanted to circle back to, is like you asked, Julie. So if a child is born with a fetal alcohol spectrum disorder, unfortunately in our state, but beyond that, there aren't many docs doing FASD diagnostic assessments. So most people who do have an FASD grow up never having a diagnostic label that matches with an FASD. What happens
by the way,
for many?
It's crazy. You keep going in a second, but that is crazy if it's a disease that occurs in 1 out of 20 people may be affected.
Right, exactly. I'm with you. It's wild. And that's a whole nother, like, how do we get docs to look at this? But that lends itself to the point I wanted to make, which is that there is a bunch of bias and judgment in the way that women get asked about their use. As you guys know, whether or not you're pregnant, the way people are asked about their use. And so if a doctor says to a woman, perhaps as an example, in a leading way, you're not drinking anything, right, while she's pregnant, the kind of safe answer would be, no, not much. I mean, right. Not me. I mean, so we have to train people, medical professionals, to ask these questions in a different way that is non-judgmental and that is supportive. And part of the trick there is that if you have an FASD, you need confirmed maternal exposure to get a diagnosis. So what happens in lieu of confirmed maternal exposure, for whatever reason, mom doesn't get asked properly, or she doesn't want to acknowledge it, or some combination of factors. What ends up happening is that people who have FASD typically get a whole bunch of other labels in their lifetime. Lots of times they acquire labels that might not even be really appropriate diagnoses, like personality disorder labels, ADHD, like conduct disorder. Those kinds of kind of judgy, some of them, labels get stacked on to people who might really have brain-based differences caused by alcohol.
Right. And on that, do you guys know in America the statistics on how many incarcerated people have FASD? My research discovered, I could tell you Australia's probably a lot.
Much higher in these populations, but part of the reason we don't have really good science is because people aren't doing diagnostic assessments. So are the persons in incarcerated settings, are there people with an FASD there? Oh yeah, absolutely. Are there people with an FASD in the foster care system? Yes, absolutely. Yes. Are there people with an FASD in our treatment world? Yeah. In our recovery communities? Yeah. But lots of times they don't have that label, which is part of this unfortunate cycle that we're all in, of like trying to raise awareness because people don't know how big of an issue we're really talking about.
Before we get to the positive intervention, tell us about what's hopeful out there in terms of interventions. Like, what support is available? Like, what programs, what can we do once it's identified? And I want you to talk about children, which probably you know a lot, and maybe speak to adults, somebody that would show up in our facility. Like, what can Julie and I do? And this is past the development when they've been misdiagnosed, they're in the system, probably institutionalized. Mm-hmm. What can we do? How can we adjust our treatment or behavior to help outcomes, help their health?
Well, luckily, there's some relatively straightforward things we can do to help. And one is understanding that people might not be where we assume they are based on their age, their chronological age, we have to always think about kind of stage, not age. So where is a person in their thinking level about life circumstances? So maybe they're entering your work, Julie and Dr. Powers, in the treatment world, and they're kind of like, okay, here I am, like I got sent here, or I'm here now because I want to make a change. Whichever reason they're entering the door, the question becomes, how can we better support them? And I like the idea generally of thinking, what do you actually need? And really listening to that, hearing that, and also observing, how can I best support the person? So some simple strategies are, persons with an FASD, remember we mentioned earlier, aren't necessarily great at abstract thinking. So one of the strategies that we know works well is providing information in multiple formats. So instead of just what happens often when a person enters a treatment setting, they get like a huge rule book, right? And they're told, follow these rules, do what you're supposed to do, and see it through, you'll be better on the other side. Like, okay, that's a really abstract concept when I've just been through this part of, or am in this hard part of life. So instead of saying, here's the rule book, we can say, here's the rule book, and let's talk through this together. What does this look like? What does this mean to you? How will you do this? And then providing visual reminders in a non-judgmental, non-punitive way. That's just a single example, but basically breaking things down into smaller chunks is a really helpful approach. Using methods like role play is a really helpful approach of practicing a social scenario, for example, that might otherwise be a trigger for a person who's in recovery. We might want to act those situations out rather than just telling people, you need new friends, don't hang out with the same people, do better. Like this kind of patronizing messaging isn't good enough and isn't helpful.
In some ways it's hopeful, in some ways it's not. One of the things we're learning is that fetal alcohol is actually a whole body disease. It's not just the brain. And there's a cardiovascular component, there's endocrine components, there is metabolic components. It is possible that if you pay attention to the surround around the brain, the person's cardiovascular health, endocrine health. Actually, one adult with FASD told me once that maybe if you take care of my hypothyroidism, I might not be intellectually disabled as all that. So if you, as a physician, look at the whole person, there may be things that you can do once you discover that they may be hypertensive, for example. It's surprising how many, even teenagers with FASD are hypertensive. So if you look at that, maybe if you control hypertension, other things might work themselves out. So maybe the hope is if you can look at the whole person rather than their brain function.
Thank you. That's well said. And Leah, what you said was great too. And I just got to brag on Julie, and it reminds me of an email that she sent out to everybody that works for us. And it was exactly that advice. Like, okay, guys, slow down. Let's figure out where the person's coming from. Let's just pause. And they're not being defiant, but maybe it's an understanding issue. Mm-hmm. And how can we communicate it in a way that they take it in?
Right.
So
way to go, wonderful. Julie. I also think categorically across the spectrum of FASD, I really think, as a social worker, I think everyone in the world needs therapy. Honestly, I really think we could all benefit. But mental health supports we know are really important for persons who have invisible brain-based disabilities like fetal alcohol spectrum disorders, because as we described earlier, they're often getting all these labels in their lifetime, and they're often not meeting others' expectations for years and years and decades. And that feels crappy, frankly. And so reminding ourselves that everybody has needs and everybody has strengths and abilities, and we've got to be intentional about finding them, highlighting them, using them to better support the person is a good reminder too.
Yeah, absolutely. There's a great YouTube video about the strengths of kids with FASD. And that is, I sent Julie the link, and kids are they want to be helpful, they're motivated, but they'll tell you they understand it and they'll show you, but then the next day they completely forget. And they're not trying to be defiant.
No.
Right.
But man, it feels, if you're the parent of a person who fits that description, it feels like manipulation, right? You feel like, oh, they are just trying to be difficult, but really, not necessarily.
Well, I'm really grateful for the work that Leah, that you're doing, Dr. Miranda, the research, all of that, and super grateful for Linda Kagi for connecting us today so that we can have this really important discussion on fetal alcohol spectrum disorders. And really, I learned a lot preparing for this podcast, and I hope our listeners found the information to be informative as well as helpful in looking at ways that we can really start reducing the stigma around this and things that we can just do within our own day-to-day, because we come across kids all the time, and maybe now we'll approach them a little bit differently. maybe from a place of understanding more so. Thank you so much. We are going to go into the positive intervention part of our podcast, and I sent it to both of you. I don't know if either of you had a chance to participate, and hopefully you did and are willing to share. Dr. Powers is going to share a little bit about the PERMA component for our listeners at home that are doing the positive interventions. This was a great one. You guys really got in on a good one. So I'll turn it over to Dr. Powers.
Yeah, this is. So part of my positive intervention work today, I'm going to sprinkle it in with the explanation of what this is. So to begin with, having a podcast wasn't my idea. It's not like I had a brainchild and I wanted to have this podcast. It was something that the owner and the marketer, they decided we need content. This will be good. And so I said, all right. And I'm an introvert, not really. I didn't think I would enjoy this, but I totally do. And part of Julie and I's vision and goal for this is to help people have hope that if you're struggling with something or you know somebody who's struggling with something, be it substance abuse or any mental situation going on, any psychological situation going on, then we can hopefully be a resource, maybe a lighthouse. And whether or not you have a substance use disorder or a mental disability or anything, if you're just what we call a normie, a civilian, somebody without the science behind positive psychology will help anybody flourish. So one of the things is also to help people increase their overall well-being, whether it's increasing positivity, engagement, relationship, meaning, or achievement. With that,
so today in our Positive Recovery Daily Guide, today's positive intervention is, what are you holding on to today? Are you living to shield yourself from pain, or are you living courageously? Can you try to let go of fear today? Apply energy today to noticing what you are holding on to and why. At the end of the day, journal about your experience.
I was fearful and holding on to kind of getting negative feedback on this, anything I do, but especially I've just, for a long time, I don't like the way my voice sounds. I don't like the way my face looks. So I avoid watching myself. I avoid listening to myself. I don't like sort of being the center of attention a lot. And so I looked at that and listened to myself and looked at myself and was open to maybe changing the dynamic a little bit and getting feedback, because we're starting to get feedback. And like I said, this wasn't a brainchild, and Julie and I, we're going to figure it out and patch this. We're going to make this work and be a good resource. And we're just building it as we go. So I was a lot more open to that. And, journaling, I found that it wasn't a hot poker that kind of brought me down. It's actually a good thing.
Thank you for sharing that. That was awesome. And you always look good and sound good on these podcasts. Leah, how about for you? What was your experience with the PI when you first read it and you knew you had to participate in this way? How did that feel for you, or what did that look like?
Well, I will admit that I was resistant to the idea when I saw it. I'm like, what? I have to talk about my own personal life for this? Wait a minute, hold on. But what I think was the fear that I sat with when I took from reading the PI as I was fearful about a podcast format, and particularly a podcast format that is with people that I don't know well. I've read about you. I knew you existed, but I didn't know you. And I thought, what if went down this rabbit trail of worst case scenario? What if they're really hateful about people with substance use disorders? I would hope you wouldn't be given your work, but you never know. There's a lot of stigma and bias within our own self. Truly, that's what I was sitting there concerned about. And I'm like, what if they question us in ways that we can't respond appropriately about that kind of topic? So anyway, I was spinning my wheels about being on a podcast generally, because it's a new format for me. We've done a lot of presentations in my life, but never in this kind of cool conversational way. And I was reassured by Linda and Dr. Miranda that you guys are great people and that it was going to be fine. And it has been really good. And so I'm glad to have been kind of listened to my supports and asked them what they thought about that. And they were more rational than I was being. So
thank you for sharing. You did so great. Things you said, I wish I thought of.
Well, thank you very much. That's very kind.
So Leah, I'll bring you back around because this is what I often do. You didn't really say what you were letting go of. I heard what the fear was that you were sitting in, but I didn't hear what you were letting go of.
I would say I'm letting go of a little bit of, a little bit of ego, a little bit of I might not come off as my very best polished self. And that's okay, because the bigger goal is getting people to have more awareness of this topic that really matters to me. So
yeah. And I think that the way that you expressed it and what you shared really can help our listeners. So thank you for sharing the way that you did.
Thank you.
All right, Dr. Miranda, you're in the hot spot.
I have to say, as a scientist, I'm not given much to doing these types of exercises. So this is a new one for me, and I wasn't sure what to make of it. The one thing that got my attention was the issue of fear and trying to let go of fear. I guess I have a different take on it. I tend to think of fear as a very human. Actually, even we share it with all vertebrates. Fear is a sense that something might go wrong, or something that might happen, but we can use it in a very positive way. And, I, rather than letting go of it, my tendency is to use it to my advantage. And one example would be when I teach. When you get up in front of a class of, a couple hundred students, you do have that sense of fear, but you can use it as positive energy to reach out to people. So I don't know if it is meaningful, but rather than letting go of it, to see if you can embrace it and use it to your advantage. I don't have big theories and words here for this, but that's what
I appreciate you sharing. And one thing that I took from your share was that when you said I don't have a lot of experience with this kind of stuff, neither do our clients, and sometimes neither do our listeners, and neither does anyone when they start into this book. But what it is, it's just a daily intervention of some type of action that we can take to make a difference, to make change, and for it to have an impact on our lives, and maybe the impact on the lives of others. And so, Dr. Powers, when you were creating these daily interventions, what would you say is like your number one hope for people when they're completing these?
Part of growth, part of any meaningful activity that can at some point add to well-being, right? Not everything is going to be a huge leap, right? Sometimes it's the little things, and getting some insight, maybe pausing and looking at what's going on can help you determine, all right, is this the path that I want to go on? So what I'm hoping is that doing each of these interventions on a daily basis will have a cumulative effect. Right? Not one thing is going to be this magical experience, because that's just not how evidence works, right? This isn't like a promise of everlasting happiness. That's like self-help phooey. But I also want this to be difficult enough that people don't just like, oh yeah, well, you just scratch the surface and that's it. Like I was afraid of eating potatoes. Now I'm eating potatoes. Dr. Powers is crazy, right? But it's more of like really digging deep and finding the fruit that's there over time.
I think it's great for our listeners to be able to hear that too, because each week we highlight the next. And so for day number 13, and also Leah and Dr. Miranda, I do want to just share with you that we are sending you your very own copy of this, so that maybe if you want to, you can continue with the positive interventions and they can have that cumulative effect for you as well.
Awesome. Thank you.
Yeah, for sure. The quote that this day 13 starts with is, "The hardest arithmetic to master is that which enables us to count our blessings." Eric Hoffer. In the daily grind of the rat race, people easily lose sight of what they are actually working and living for. They become easily preoccupied in temporary and false doorways to happiness, such as money, status, and prestige. Sufficient financial resources are necessary in life, but once basic needs are met, money's contribution is tricky. When precious time and energy are forfeited to pursue fiscal ends, people experience diminishing returns for all of the effort. Instead, be grateful. Practicing gratitude is a healthy and sustainable combatant to the rat race. Gratitude decreases or prevents negativity, helps cope with stress and trauma, increases self-esteem, and builds social bonds. What do you love most about your best friend, children, family, work, car, home, sobriety, or life that has recently slipped your mind? So the PI is focus on one thing that you usually take for granted and mindfully approach it from an attitude of gratitude. Tonight, journal about any new insights gained from applying the day to appreciating that one thing. So I know I'm going to have fun doing this one. So thanks so much, Dr. Miranda and Leah. We really appreciate you being here with us.
Absolutely.
Thank you, guys.
Thank you for having us.
This is Powers and Denofa signing off. Thank you very much.
Thank you for listening to this episode of Positive Recovery MD. Don't forget to visit positiverecoverymd.com to sign up to get your daily positive intervention sent straight to your inbox. Be sure to subscribe to Positive Recovery MD on Apple Podcasts or wherever you listen to your podcast to receive an automatic download when a new episode drops. And as always, if you or someone you know needs help, Visit positiverecovery.com or call 877-4SOBRIETY, which is 877-476-2743. We are here to help.